Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from MERS Aesthetics.
Hi, and welcome. Welcome to this very special Medscape event where we will be focusing on advances in dermal fillers and specifically on hybrid fillers and as well on as the power of regenerative biostimulation. So I would like to start by introducing myself. My name is Yanni van Lochem. I'm an aesthetic physician from Amsterdam, the Netherlands, working at UMA Academy. And today I have with me the amazing, very well-known Professor Martina Kerscher, who is a full professor at the University of Hamburg in Germany.
Thank you.
Welcome. And also I have with me Dr. Stefania Guida, who is an assistant professor at the University of Milano in Italy. Welcome, Stefania.
Thank you. Good evening.
Great. So let's dive straight into what we're going to be talking about because we have, of course, limited time to discuss a lot. So we're going to start by one of the pioneering works that Professor Martina Kerscher has published with none other than Kate Goldie, who will come back in this conversation as well. And they talked about in their publication on what is skin quality exactly. Martina.
Well, thank you so much, Yanni. Skin quality is really a topic that goes close to my heart because it's so helpful for all our patients in each age group, in each ethnicity. And skin quality means that we have to look that our patients have a useful skin, an undamaged skin, and that we can assess by using 4 skin quality categories. This means we have to assess skin firmness, skin surface evenness, skin tone evenness, and skin glow. And to assess these skin quality categories, we cannot just have a look at the face. We have to touch our patient's skin. We have to assess the skin and have to do a pinch test or a snap test on the back of the hands, at the décolletage, or in the face, in the lower cheeks, or on the forehead, to get an idea, for example, about the skin firmness of the individual patients. And after assessing the different skin quality categories, we have to decide about the individual treatment plan. And for the individual treatment plan, we have to start to treat the most predominant skin quality category. And for this, fillers and biostimulation is really mandatory.
So, Stefania, you have a very nice introduction to biostimulatory products.
Thank you. So yeah, biostimulatory fillers basically can induce biostimulation in the skin. What does it mean? It means that they can create a new extracellular matrix. So basically, they stimulate the production of collagen and elastin in different ratios and proportions according to the filler that we choose. And specifically, we will see why some of our choices points out the importance of calcium hydroxyapatite, which has unique properties since it is hydrophilic, so it can be combined with lidocaine as well as with saline solution in different proportions, and also with HA. And talking about HA, we know that there are controversies, right, on the fact that it has biostimulatory properties. So some says that it is just a scaffold effect, but we know from recent data that it is possible to improve the collagen density with HA, as well as, it has a role in mechanical support, of the skin.
So that is actually something that we've known for a while, that there's HA that can induce collagen production, and there's also this biostimulatory products, those that can definitely induce collagen production. But regenerative aesthetics is relatively a new term. And to actually understand what we are talking about, we can go to the literature. And Dr. Kate Goldie from the UK has been doing some very amazing pioneering work. And she sat down and actually went and interviewed and did a lot of research about what is regenerative medicine and how does that differ from regenerative aesthetics. Well, in regenerative medicine that we've known for a long time, we focus on the regeneration of injured or diseased tissue, whereas with regenerative aesthetics, we actually want to bring the tissue back to a more youthful state. And that means for a product to be regenerative, it has to comply to a certain amount of conditions. First of all, there has to be cells that need to be activated. In our case, in aesthetic medicine, we are of course talking about the fibroblasts. Now, the fibroblasts can be activated, but only fibroblast activation is not yet regenerative. A second pillar of regeneration is there have to be biocues. Now, in this example, you see some exosomes, and they are very strong biocues to activate cells. And also, we need scaffolds. And scaffolds are three-dimensional structures that are actually used for attachment of fibroblasts with their integrin molecules. And in this example, you see that these are collagen fibers. So the collagen fibers on the extracellular matrix are necessary for fibroblast activation. And we also see that, and that has been published in many studies using histology, where we see the fibroblasts attached to the collagen fibers, and they show definite activity. But also the three-dimensional scaffolds in some of these regenerative products, and calcium hydroxylepidide is actually the first one that really truly ticks all the boxes, can function as a three-dimensional scaffold, because in histological studies, it shows that the fibroblasts are actually moving towards the calcium hydroxylepidide microspheres. Probably the chemotaxis there, where they move to the calcium hydroxylepidide microspheres, is because of biocues. The biocues may be the calcium that is released from degradation of the calcium hydroxylepidide microspheres. And when they attach to these calcium hydroxylepidide microspheres, or CAHA, then they are activated and they start to produce different components from the ECM. So the difference between some other products is that they, as biostimulatory products, they induce most of the time collagen production. But a true regenerative product will regenerate not only tissue structure in a normal way, which means the normal composition of the proteins, the extracellular matrix components, and also in the normal ratio. So not just one bulk production of collagen, and it will also result in a normal functioning of the tissue. We have three little videos, one of the assessment, where we'll do a structured facial assessment, and we can all three comment on what we see, and then the preparation of the products, the blending of the hybrid, and after that, we have a video of the treatment. So, ladies, this is my patient. She is late 40s, and she has done some previous work, but it was the first time that I saw her. So, what is the first thing that jumps to your mind, to your eye, Professor Kerscher?
Well, first of all, she is indeed very attractive and has a good skin quality. That's what I see at the first glance. But on the other hand, I also see an asymmetry on her right eye. The eyelid is sunken a little bit and the eyebrow was a little bit deeper on her right side than on the left side. This is the first thing. Then I would do a structured assessment of skin quality, like you do it right now, as I can see, to get an idea about her skin firmness in the upper third of the face, about a possible bone resorption, about her mimic activity.
You see a little bit of bone resorption, I think, right now in the forehead, right? A little bit of frontal concavity.
Yeah.
Some temporal hollow also. the lateral aspect is more clear for the ball resorption.
Yeah. So now we move to the middle third of the face. And I think, also we can comment a little bit on, the skin color, because I think, what do you see, Stefania?
I see a little bit of redness, just a few pores visible, right? So perhaps we can address that also with some lights or other tools, but also with some, biostimulatory fillers, right?
Absolutely. And looking at age-related anatomical changes, is there something that you would like to comment on, Martina?
Well, in general, I think she has a really good bony structure on her cheekbones. That's in her mid-face really important, but she has a little bit of loss of volume in the lower eye area.
Yeah.
That's what I
Palpebral
see.
groove, right? And a little
Yeah.
bit of infraorbital hollowing.
But lower 30 is quite nice.
Yeah.
Right?
Yeah. But that you see me pointing out there, that is a scar, a surgical scar, because of the facelift that she has undergone, where you see that the lobule of the ear is actually almost continuous with her cheek, her lower cheek. See here a little bit of collagen loss, actually, age-related collagen loss.
Yeah.
I think she has a loss of skin firmness if you do the snap test,
Excellent.
even if she has a great contour and even if everything is here looks perfect. During assessment, you can see that skin firmness is not at the highest level.
So one of the most things that she wanted me to improve was actually this little line over here.
Okay.
And she was quite bothered by the fact that the scar was visible, the surgical scar. And of course, she was very open to this very structured facial assessment. And it's only an edit, of the whole assessment that I did. So that brings us to the next video, which is the preparation of biostimulatory products and actually the diluting of calcium hydroxylepatite with first lidocaine. This is the original product, the non-lidocainized product that I use, and I'm mixing lidocaine through the gel. Now, the gel has a very high viscoelasticity, right, Martina?
Absolutely. If you do rheological measurements, it's more than tenfold than even the highly viscous HAs that we usually use.
Mm-hmm.
That's what we have to have in mind if you use it not for contouring, but for skin quality improvement. And that's why you dilute it, I think.
Yeah, and I make sure here when I push the lidocaine through the connector to make sure that there's a little surface on the top of the connector. So there's a little drop of liquid coming there in order to avoid any air in the system. Because I will mix vigorously, I will mix that calcium hydroxylepatite product through the lidocaine.
How much lidocaine do you use, Yanni, for 1.5 ml of calcium hydroxylepatite?
Well, in this case, this is the FDA-approved 0.26 milliliters of lidocaine, but of course, off-label, I dilute it much more. And the diluted calcium hydroxylepatite 1:1, so that means 1.5 milliliters of calcium hydroxylepatite with 1.5 milliliters of diluent, has shown to be the most potent regenerative mix blend dilution.
Absolutely, also in my experience.
Yes. But also we can hyperdilute. We can even move to a more liquid version. So the original version is very strong, highly viscoelastic scaffold. The minimally diluted is a more forgiving regenerative scaffold. And this, where there's a lot of saline mixed, can be used for very superficial, very thin skin areas. And that is a liquid regenerative scaffold. And now, in this video, I show one of the possibilities of creating a hybrid filler. Now here, I use a little bit of dilution, so 0.5 milliliters of lidocaine, and I add 1.5 milliliters of calcium hydroxylepatite and 1 milliliter of hyaluronic acid. This is CPM hyaluronic acid that already is a very smooth and light, low elasticity, low viscosity product, highly cohesive. And I use that to create a mix that contains the regenerative calcium hydroxylapatite particles as well as the hydration that we can get with HA.
Just to make sure I've got it right, you dilute calcium hydroxylapatite or you use it as 1.5 mils as it comes in the syringe?
Well, you can have different blends of hybrid. And of course, I don't know how you do it, but I mix and match depending on what kind of clinical situation I have and what my intention is of what kind of effect I want to achieve.
Certainly, I think that's the most important point.
Yeah, it is. And how many passes do we perform? I mean, actually 20 or also 10, less than 20?
Usually more than 20, more like 30.
Yeah,
especially
right.
when the HA becomes more cohesive, more thicker, more elastic. So let's move to the video of the patient treatment. And I always start at the upper third of the face. So what do you see here, Martina?
Well, I see a treatment that's really in a high danger zone. I'm absolutely sure you know what you're doing, but I think that's important. I see that you are using a cannula, which
22 gauge.
22 to make it as safe as possible. And in which area, in which plane do you work?
So the direction of the area is perpendicular to my enemies. And my enemies are the supraorbital and supratrochlear arteries. And the arteries are located either in layer 2 or layer 3 in that area, which is just above the inferior frontal septum of the forehead. And that means the safest layer to inject is layer number 4, which is the subgaleal glide space.
And your objective is to lift up a little bit the eyebrow to have more support?
Yes, exactly. So the first of all is correction of age-related bone resorption, creating a concavity in the forehead. But a very nice side effect is that it will help in lifting the position of the brow.
I can see the patient is quite calm. Mine would have been shouting all the time.
Yeah, but I'm cheating here a little.
Okay.
She's had a full upper face nerve block, so supratrochlear, supraorbital, and zygomaticotemporal nerve blocks. And that will make that treatment very doable for this patient. So I make sure that I inject no more than 0.025 milliliters per retrograde linear thread. I hold my non-dominant fingers on the nasion in order to temporarily close the supratrochlear artery there. Just all prevention and preventative methods.
And you use a highly cohesive hyaluronic acid.
We're moving now to the temple. As you mentioned, Stefania, the temple showed a little bit of
all those, yeah. And also, I mean, you can see very well how you manage the cannula, taking your time, but also
being precise. This is in the interfascial space, so between the superficial and deep fascia. And the reason that I know I'm there is because I go from the periosteum of the frontal bone, slide laterally over the temporal crest, and that is the same layer, the periosteum of the frontal bone is the same layer as the deep temporal fascia. And so from layer 4, I stay in layer 4. Now, this is nice that somehow this patient presented with the scar, because it allows me to share with you how you can use regenerative products like calcium hydroxylapatite to improve the clinical situation of a scar.
How old is this scar? Do you know it?
Oh, the scar, yeah.
Because it's a white scar, so I think it's not a fresh one.
Not a fresh one,
really
absolutely.
An older
I think it was
scar.
6
That's
years
also
ago or
good for
something.
our patients to know that we can even improve older scars.
And of course, there was quite some retraction of this scar, and the retraction caused in also more visibility, a little bit of shadow, and then next to that whitish discoloration of the scar made it extra visible. And so at first I tried to blunt this section to release the scar from the subcutaneous tissue, but it wasn't enough, especially in the medial part. And so here you see me using a 23 gauge needle to kind of do like a needle rigotomy and to release the skin from that subcutaneous tissue. And also then, of course, injecting a lot of product in order to keep some distance between the skin, the released skin, and the subcutaneous tissue.
And this is calcium hydroxyl apatite, I guess?
Yes, this is the standard dilution.
Okay.
So it's not the 1-to-1. And you see, I squeeze out a little bit of product. I didn't want to pretend it wasn't there, so I left it in. And then we move to the sunken upper eyelids. You can see I am using the hyaluronic acid syringe, and inside I am using a hybrid filler. Now this is a 1-to-1 of the calcium hydroxyl apatite. And then I use, that is half of what is inside, and the other half consists of the soft hyaluronic acid.
Why the mix, for this area, for this specific patient?
Mm-hmm. Yeah, the reason is that I wanted to add calcium hydroxyl apatite microspheres because, first of all, it will induce some improvement of the skin, even though I'm in layer 4, which is the preseptal space. But more importantly, there's a lot of patients, if you do it with only HA, that will complain of swelling, swollen eyelids, a lot of edema if you only use the pure HA. So therefore, in my opinion, in my clinical experience, using a blended hybrid is actually giving less swelling.
And it brings much more for tissue regeneration. That's really helpful in the upper eyelid area because otherwise we don't have too much treatment modalities.
Yeah, we have lasers,
Yeah.
we have maybe microneedling,
Yeah, but I think to give this really biostimulatory effect and to improve all the different components of the ECM, that's quite a smart solution.
The most important safety message when treating this area is to use very small quantities when you inject and then go back and readvance and do another very small quantity. But take your time, because if you make one mistake and you inject a little bit too much, you could actually blind your patient.
And it's amazing. Just have a look at the patient. The asymmetry is almost immediately gone. And that's perfect result.
It is.
And the really important thing is that to keep to the small
Quantity. You can always correct later, right?
Here I wanted to add a little bit of hyaluronic acid with the needle technique. Of course, everybody knows the gunshot technique, but I call this the machine gun technique. And the reason is that instead of injecting one big bolus, I take into consideration the fact that the deep temporal artery there is running very close to where my needle is extruding the HA. And that means if you inject enough product, you can reach the deep temporal artery, which also connects to the ophthalmic artery and the central retinal artery. And therefore limiting the amount of product to, in my case, I use a maximum of 0.05 because that small amount makes it very unlikely that if you inject there into the artery, that you will actually reach the retina.
I think that's a really important point to increase safety in this relatively dangerous area. But now we are already in the mid phase, the upper cheeks. And you're working with hyaluronic acid, as I can see here.
Yes, I'm using a high elasticity hyaluronic acid. I'm using a cannula, 25 gauge cannula. And I just want to target the zygomatico-cutaneous ligament in order to create a little bit of a lift of the cheek.
And even here, you use not too much HA. If I see the syringe, you are really injecting small amounts, but precisely.
Yeah, so if I want to have an optimum lift with a limited amount of product, I have to be smart. And therefore, when you want to lift, it's good to target the retaining ligaments because they have the maximum lifting capacity.
And maybe you can do some regeneration, or we can achieve regeneration of our ligaments too if we precisely inject our HA, because they also have fibroblasts.
Yeah, so actually a stronger regenerative effect would be with calcium hydroxylepatide. And over here, we're already moving to the next area. So normally I will work top down, but there's an exception for the infraorbital hollows where I usually start at the cheeks because they're the basis of the infraorbital area. And then, so from the cheeks, I go upwards to first lateral, the palpebromalar groove, and if necessary, then the tear trough area as well. So now there's a little assessment. So maybe, Martina, you can comment on what we are seeing. So the A-frame deformity that you saw, you see there's a block now because I anesthetized her right side. And so normally we would expect the right side, the right brow to drop. But as you can see, that brow is actually, is having a very nice position still. So if the anesthesia wears off, it will probably result in a lift.
Slightly arched, and we see more of the upper eyelid. The free and moving upper eyelid is almost symmetrical between right and left side, and this was in the beginning a huge difference between the both sides. So it's an amazing result there. And she's lost her tiredness. When we saw her before, she looked a little bit tired and that's now she has got a treatment, but this tiredness is completely away. What do you think, Stefania?
Yeah, she looks now younger on the right side, right?
Do you see that her right canthal position has lifted a little bit because of the palpebromalar groove injection?
Yeah. And this also influences tiredness and sadness that can be brought through this.
So do you usually use hybrid filler, Stefania?
So just in some cases, in those patients that do want to achieve, do want to see the result from the very beginning, in order to have the HA to keep the result also in the, let's say, first 2 months bubble if it is a patient in menopause.
So in this case, I'm using the blend of 1 syringe of calcium hydroxylepatide, 1.5, then 1 syringe of hyaluronic acid and 0.5 milliliters of lidocaine. And after this really important part, the upper and middle third of the face, we come to the little details and the lower third. So one of the little details is oral commissure, because the right side was a little bit lower than the left side. I'm actually injecting her weak side first to bring it up, maybe even past the strong side, like I'm doing now. The corner is now a bit higher than the left side, so I probably use a little bit more on her right side. But it makes it easier for me to create a symmetrical outcome if you start at the side that needs the most work, basically.
And it is interesting, I think, also to see how to correct the volumes. The volume loss is important also to address the skin quality issues, right? So it's not just about the biostimulatory fillers, but also to have an overlook of the patient.
And I think over time she will have a benefit from skin quality improvement on the cheeks that you have done, that will also lift and tighten her oral commissures.
Yeah, it has been shown that, because calcium hydroxylepatide will dissolve and it will, create calcium ions and phosphate ion, the waste products. But calcium has been shown to stimulate fibroblasts and also to stimulate them into differentiation into myofibroblasts.
Absolutely. It's one of the essential ions needed for the fibroblasts. So that's amazing.
And myofibroblasts also have contractile capacity, which makes it actually also understandable that you can see that lifting, that tensory effect, that tightening effect of after calcium hydroxylepatide.
So you're on the chin. That's what I'm seeing here. And you are using a needle?
I'm using a needle.
Correct?
Yes. And of course, I'm doing a small bolus injection. So the maximum amount that I inject in the chin is 0.1. And if I need to do more, I just retract a bit, re-advance, touch periosteum again, do a small bolus of maximum 0.1, etc.
I think that's, again, an important fact to make it safe, as safe as possible.
Mm-hmm. Now, because she had this scar visible from the facelift, the lobule looked a little bit unnatural, and therefore I used a little bit of hyaluronic acid in order to, restore it's actually kind of a reconstruction of normal anatomy.
This is interesting. I mean, can be applied also in some cases where there is, lobe with.
So this is a 2-hour video, and this is only a cut, so we can also only discuss a few items of it. And I'll finish off with hyaluronic acid blanching. Over here we see this is not possible with all the hyaluronic acid products.
Absolutely true. I think for blanching techniques, we need hyaluronic acids that are able to immediately integrate perfectly within our dermal tissue, because otherwise we can get Tyndall effect, for example, or HA that is visible as a small lump on the skin surface. So blanching technique, but it's great for these lines, and for the patient, she has an immediate effect.
So now I use my nail to actually smooth out those little nodules. This is, a relative. There's different strengths of HA, and this is still some viscosity here, so I kind of have to even out the product. You see a little blanching effect that will disappear in about 10 minutes after this. So knowledge is beautiful. And that brings us to the end of our session today. Make sure that you complete the evaluation form. So I would like to thank you very much. I would like to thank you, Professor Kerscher, for doing this. I would also like to thank you. We've learned a lot about how to use hybrid fillers and what is regenerative aesthetics, actually. And we specifically talked about structured facial assessment, including structure of skin assessment, but also age-related anatomical changes and face shape. So with that, I would also like to thank you for tuning in.